Good afternoon to people that are just getting joined here. You're reaching the presentation for the Care Canvas training. Hi, Deb. I see you're on too.
Good afternoon.
Yes, good afternoon. We have sunshine finally, and this nasty weather we've had for 2 days is finally blowing through, so it just feels good to have that sunshine in.
I bet there were some flurries driving into Duluth this morning, and they're heading in our direction, actually, I think.
Yeah. So just to folks that are getting signed on, Ashley has put a reminder. We're just asking so that we can kind of help keep track of who's calling in, and just your email address also would be helpful. So your name and your email and the place of where you're from would be great. That way we can include you in future invites to other care coordination activities that we're doing. So I want to just be able to do that. Yep, I see lots of people calling in. So we got a couple minutes here at the top of the hour. I got just a very small introduction, Deb, and then I'll turn it over to you to kind of give more details. So hi, Brad. We're just trying to get started here. Yeah.
So how has been the weather over your way, Deborah?
You send it our direction. It's been wet. We haven't gotten the inches of snow that you guys have. It's been a little more tempered here, I think, but it's just been so wet and so windy, and looking for sunshine.
Yeah, it wasn't our a deliberate intent to send it your way, but yeah, North Dakota is all over the map. I mean, Jody got snow. There was heavy snow west of her. There were towns that got 12 inches on top of the 20 plus inches or so they had the week before. Here in Grand Forks, you know, we had gotten some snow last week too, but not as much. And now it's just been just heavy rain. The Red River is way up. We two of our 3 bridges in the Minnesota are closed. Now because the temperature drop, it's like driving on an ice rink out there today.
Yeah. I sure hope you folks in Grand Forks don't have flooding. I mean, I know the bridges are going to be closed, but hope it doesn't hit anybody's houses or anything like that. So
and I know some people have been finding water in their basements, but you know, if it holds the way they're talking about, you know, it will be one of our higher levels, but you know, we're protected up past 54. I mean, 54 inches was what we had, 54 feet was what we had in 97, and we're protected above that. And this is likely going to crest at 48, 49.
Yeah, well, fingers crossed.
Gets everybody nervous.
Well, we are at the top of the hour, so I think I'm going to just jump to it if I could. I see there are a person here or two that are still getting signed on, so that'll give us a moment here to do some introductions. And then after I introduce you, Deborah, do you want to explain how we're doing the webinars and then going to host office hours, or should I kind of explain that too? Okay, I'll try.
It's really up to you. I'm going to remind everybody of the office hours at the end.
At the end. Okay, so I'll say it, then you couldn't say it again. So I'll just say again, as you're getting signed on this afternoon, welcome. So happy to have all of you take out time to join us. We would like, if you would, just your name, email, and your organization, if you would, in the chat box. That way we're sure that we include you in future offerings for care coordination. Just want to make sure that we have an inclusive email list so that we know that, that we're reaching out to everybody. And then secondly, I just say, I'm Jody Ward. I'm with our Flex program. I'm program director, and also Brad Gibbons is on. He was talking a minute ago. Wait, Brad. He's our director for Center for Rural Health, and I have a couple more teammates on. I see Nicole, Anna, and Ashley, all teammates of the Flex program, and so happy that they're here too. And then of course all of you. And we have some fun stuff planned this year for care coordination. So many offerings with Deborah Lane, and Deborah is with the Rural Health Innovations Center, part of the Technical Assistance Center for all Flex programs across the nation. So we're very happy that we've been taking this journey with Deborah Lane, and we'll be offering at least 5 of these webinar our Zoom sessions on various topics around care coordination, basically as kind of a refresher, because with COVID, we've had that pause in our activity, but we're picking it back up. And then just in discussions this morning with Blue Cross Blue Shield and Pat Spear and all the work that we've done around care coordination with their group, we are planning motivational presenter up and coming, like I think it's September, but you'll stay tuned, more information to be sent on that. So with that, I want to introduce Deborah Lane. She's Senior Program Specialist, again, with the Rural Health Innovations. She's got over 30 years of adult education experience, coaching, technical assistance, all around jack of all trades, I think, and we've sure depended on her for care coordination, and she definitely has a passion for rural health communities. So you can say more about yourself too, if I missed anything, but we're just very pleased. And then I think I'm stumbling here because I forgot to say that we're doing these 5 webinars, but after each webinar, you're going to see an invite for an open office hours, meaning that you're going to hear the content today, and that'll give you a week to kind of meet with your own teams. Think about a plan to be acting on some of the information that you learned from today. But if you have questions or just kind of still stumbling about how to get started or whatever the what is, we're going to have these free hours that are open a week afterwards that you'll have access to Deborah Lane to ask questions. So you can bring your team, and it's just an open platform to tap into her as a resource. So we can explain more during the presentation, but I'll turn it over to you, Deborah. Thanks.
All right, thank you, Jody. I'm just really happy to be here with you today, as well as we go through the rest of our summer months here and talking about something that, yes, I do have a passion for, a deep passion for, and I will be explaining a little bit about that in a bit here. So welcome to Rural Care Coordination, an engaging, collaborative, and innovative approach. And as Jody said, I am Deborah Lane. I'm a program specialist, team lead at Rural Health Innovations. We are a subsidiary of the National Rural Health Resource Center. And as Jody mentioned, TASC, or the Technical Assistance Center, is part of our greater center. And our mission of our organization is totally focused on sustaining and improving healthcare in rural communities. And we work with communities like yours across the United States. And to me, it's just a real honor to be doing that. Rural care coordination. As members of rural communities and rural healthcare organizations, you tend to approach things with very much of a can-do-it attitude and are very resourceful people. You're a person that's dedicated to the health of your community members, and that's the why for many of you in healthcare. You are people that just naturally connect with others, and through time, you've learned that working together, you can accomplish much, much more. And almost always, you're ready to try something new in your communities. And today, I would like to introduce the Care Coordination Canvas to you. And the Care Canvas is, I think, really uniquely fits rural communities because there's not one rural community alike in the United States. You all have your own uniquenesses, and this canvas allows for flexibility and adaptability to your organizations. My hope is that by the end of our time today, you'll be able to recognize the role that care coordination plays in population health and value-based payments, and be able to define the care coordination canvas components. And with the use of this tool, begin to identify the components within your organization's current efforts in care coordination, and discover the areas that may need strengthening and those that are very strong. Care coordination is the key that unlocks the door to value-based payments, as well as a healthier population. It's absolutely no secret that we are moving from the old and familiar health system, the health system that many of us may have started in, of higher cost, lower quality, high chronic illness, and low access, to the triple aim. So what does that matter? Well, you are likely very aware of the triple aim or the quadruple aim, first coined and trademarked by IHI. CMS identified its own quality strategy focusing on three aims, and those you see here: better care, healthier people and healthier communities, and smarter spending. The triple aim equates to a value formula that you see here on the screen, where quality coupled with patient's experience, that links to HCAHPS and their perceived outcome, divided by the cost of care equates to the value. So when you hear the mention of value-based care, it isn't only about finances, it isn't only about quality metrics or readmissions, it's about that entire formula. This visual may be one of the best ways to describe what is really happening in our industry, in that healthcare industry. For years, we were in that volume, or on that left-hand side, where the payment system was based on fee-for-service, with limited financial risk for your hospitals and your healthcare organizations. Incentives were there to increase the number of services provided. There was limited communication between providers and limited focus on outcomes and information sharing. And I often just say that it just created silos. But we are well on our way to moving to that right side, to that value side, where we're focusing on high quality care at a lower cost, focused on best practices and evidence-based medicine. We are now focusing on prevention, and care coordination plays a really key role in improving communication, so we don't have those silos that we always used to have. And there's an investment in clinical integration, population health, and many other innovative models. Care is provided in medical communities versus just one clinic, one hospital. We're all working together. And payment is through such mechanisms as accountable care organizations, bundled payments, MACRA and MIPS, global budgets, and Medicaid and other insurance accountable care organizations. Which leads us to the proof of why population health matters in our organizations. CMS described the evolution of thought and practice in moving to the transition to value-based care back in the spring of 2019 at a national conference. And these were the three phases that they outlined at that time. In phase one, we have our emergency department high flyers, we have chronic disease patients, and we have high utilizers. And in that phase is the phase we've been working hard to move out of, and that's where the patient is driving our costs. And then in phase two, we're starting to look at analytics to identify patients and patterns, who are those exact patients that are our high flyers. Where are our greatest costs around chronic disease and which ones? So we started to look at things like chronic disease or chronic care management. Patient and physician engagement became important, and behavioral health integration into primary care, and then started to look at some of the social determinants of health. And this is maybe we can do things, or thinking we can do things about controlling our costs and just starting to swim in those waters. And in phase three, we truly have care redesign, maximizing Medicare benefit options. We have increasing telehealth, of which COVID has really pushed us along that continuum. We begin to challenge some of our assumptions and we really start looking at innovations of care, where maybe we need to really think about the redesign in the way that we deliver care. And the care coordination canvas is helpful in phase 2, but very helpful in that phase 3 of seriously looking at some care redesign and innovations of care. With 2 changes in administrations, the Affordable Care Act has remained. In early April, or earlier this month, the Affordable Care Act was brought into the national light with former President Obama's visit to the White House. He talked about how the Affordable Care Act is a continuing work in progress, and saying there has been a lot of talk about and legislation surrounding healthcare in our country is really an understatement. Through administration changes, we have had clear signaling that the train's going to remain on the track. Actually, it's already left the station, and large healthcare giants are chugging along fast on this railroad track. And the tracks may have a bend or a curve or some Y's or forks in that track, but it will continue to move forward. It's going to move forward with value-based payments, which is a pay-for-performance approach versus a pay-for-quantity approach, where it's holding providers and hospitals accountable for both quality and cost of care. Instead of only paying for the number of services provided, it is paying hospitals and providers for providing high-quality services, services that will reduce admissions. And according to the American Academy of Family Physicians, care management and care coordination are really the key components in any of the value-based systems. Yes, care coordination is at the center of these value-based models. Something that affects each of you, no matter what your position is within your organization, is this curve. Healthcare transformation, of which we know is not going to go away, is really about introducing a new business model for the healthcare industry. As value-based models take stronger hold, this will begin to change the environment, and more organizations will be forced to do business in the style of the second curve, the curve over on the right, that full value-based reimbursement. When this happens, an organization either needs to adapt to this new style of payment, or it will reach the end of its life cycle. In other words, it'll have to close shop. And you guessed it, a key part of this adaptation and comfortably jumping to this second curve is care coordination. The straddle between the 2 curves is a dangerous place to be for healthcare organizations. And your individual organizations may be in that valley right now, where reimbursement is low, return on investment is low, and there's incredible pressure on human capital to take that leap and up the slope to that new payment model, all to avoid the end of a life cycle. Now, the North Dakota Care Collaborative is here to help you bridge that gap by providing resources and trainings such as this. Before we go any further, I'd like to offer a couple of definitions that will establish some common ground as we move forward. As we were developing here at the center, the care coordination canvas, we focused on 2 primary definitions. One of those being community-based and integrated primary care, behavioral health, oral health, local health, and community resources to provide person-centered care and coordinated services, which this really is truly a community-based definition. The second definition, an opportunity to supplement the diagnosis and treatment priorities of medicine with clinical and non-clinical prevention and management in a system that also supports the social aspects of patients' lives that contribute to their health. This is from Rupri and would definitely be classified as a clinical definition of care coordination. The more our organization researched, dabbled, talked, communicated about care coordination, we really began to understand that there is a third definition, and that is community care coordination, which is a collaboration amongst healthcare professionals, clinics, hospitals, specialists, pharmacies, mental health, community services, and other resources working together to provide person-centered, coordinated care. So as I move forward today, and as we move forward with this series, these are the three definitions that really found the work as we go forward. In the next webinar, we are going to address the many different elements of community care coordination. And we'll be looking at this visual in a little more detail in at least one, if not two more webinars. Our ultimate goal is a healthier population. That's why we're in the business of healthcare. If you remember the illustration of volume to value, where in a value system, the healthcare system is networking together for the care of a population or a group of people. That could be geographic, that could be disease-based, just an interest of the healthcare organization. But the aim of value-based work is to improve the population's health through time. In order to continue with the type of results that we have started to see with these alternative payment models, we really need to expand our understanding of what creates health. Health is a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. And I'd like to use the World Health Organization's definition from 1946 as we proceed today. This isn't new. This was written by the World Health Organization in 1946 and put into force in 1948. In order to achieve a healthier population, it requires a team approach and looking at that whole person, looking at physical, mental, and social well-being. Here's the formal definition of population health from the American Hospital Association. But what we're really talking about here is changing from an illness model to a wellness model. Population health serves as a strategic platform to improve the health outcomes of a defined group of people, concentrating on three stages. First of all, looking at statistics and figuring out what are those outcomes that are unhealthy within a population, and then figure out what causes those outcomes. And we, through many communities, we may decide that we have the same particular health that we need to, or health issue that we need to address, but because of the uniqueness of our communities, the factors that cause that may be very different. And then the third phase of population health is determining what interventions will modify those factors that are causing poor health, so we can increase and improve our health outcomes. It's important to understand that medical care is only one of many factors that affect health outcomes. There are other factors such as social environment, which would include income or education, employment, social support, culture. And then there's that physical environment. Do we live rural? Do we live urban? Is the air clean? Is the water clean? What are our genetics? What are our epigenetics? And what are our individual behavior choices? Hospitals and healthcare systems, physician groups must adapt to our new world. Many organizations are well on the way to doing this. Organizations that are beginning to plan for patient-centered, high-quality healthcare delivered to a specific population are the leaders. So when we hear population health, we know it's a term that's interchangeably used for a target population, which is looking at reducing the cost for a specific group of patients. But when we talk about population health, it can also mean total community health of your entire community, of a geographic defined area. And so when you're starting to work with population health, it's important that you know exactly which of these definitions, shall we say, that you're aiming toward or working toward. And one more definition, shall we say, around population health is that it is a strategic platform. We don't do population health, but what we do is population health management. So what we do as healthcare providers, what can we really do about it? And we do it by not solely focusing on that condition that may walk in the door, walk into our facilities. We need to, as I said before, look at that whole person as we look at a definition of health moving forward. We need to recognize as providers, we only have control over 20% of the health outcomes of an individual. The care that they receive within our walls, just 20% that affects 20% of their health. So as we navigate care coordination, when we really start diving into care coordination, we're looking at improving the length and the quality of life. And so how can we support all of these other things, this other 80% that influences a person's life? That's dealing with the social determinants of health. That's where that answer lies. It is a profound concept that deserves our time and our attention to pause and review this every so often. I work within social determinants of health in these waters a lot, but it's really good for me to sit back and really review that it's the conditions and circumstances in which people are born, grow, live, work, and age in. These circumstances are shaped by a set of forces beyond the control of the individual. Economics and the distribution of money, power, social policies, politics at the global, national, state, and our local levels. Yet the disparities we see in health in our exam rooms are likely just the tip of the iceberg if we're not intentionally creating a full picture of that person that we are working with. And a lot of times the people we're working with don't let us see below the waterline, but we need to realize and figure out ways of getting below that waterline. There's a case to address social determinants of health, and these are two quotes that I feel illustrate it well. Now, again, in our next webinar, we are going to start to focus on social determinants of health, identifying them and finding community partners to work to help you alleviate them or make them not be the kind of barriers that they may currently be in a patient's life. Jay Bott from the American Hospital Association says health disparities are America's chronic condition. And if we think about that, as I thought about that, that makes just so much sense. And then what Sir Michael Marmot says, he is the chair of the Commission on Social Determinants of Health for the World Health Organization, is why treat people and send them back to the conditions that made them sick in the first place. And part of the care coordination canvas really gets you to look at what some of those social determinants of health are that affect your population. And then in next webinar, next time, and then one of the other ones toward the end of the series, we're really going to look at how do we engage these community partners to make a difference for those persons. There's a lot of partners in that we can collaborate or refer to or to lean on in our communities. Some you may already have relationships with. Some partners you can see from your building. Others are out of town, and some are even out of the region. But they weave a safety net for your patients. This is where the concept of care coordination starts to extend out of your doors and into community care coordination. In the last webinar in this series, we're going to talk about intentionally reaching out toward some of these community partners that affect the lives of ourselves as well as our family and the patients that we serve. Care coordination is the concept of connecting persons with healthcare professionals to ensure that their health needs are being met at the by the right person at the right time, and connecting them to needed community resources. It's about empowering the person, or as a care manager or care coordinator, you're bridging from the clinical to the community that your patients live in, and looking at that whole person, leading to a healthier person. Care coordination is an evolution that has taken place over many, many years. My personal experience with care coordination is from the community-based side as an end user, actually. My passion around care coordination actually goes back almost 40 years. My mother began showing signs of dementia over 35 years ago. I first stepped into the care coordination realm to find help for my father as I saw his health declining as a result of caring for my mom. The only thing that even slightly represented care coordination were the quarterly care conferences when she was in the long-term care facility. Fast forward 12 years, my dad, his hypertension was the tipping point for him. For years, there was no one to follow up and make sure that he went on the medication that was prescribed or used it. There weren't well visits, so there was no routine testing or inquiring about prostate cancer. A downward spiral of congestive heart failure events and prostate cancer thrust him into the need for help. At this point, I was excited because there was someone, a county case coordinator, that was there to link him with services, doing care coordination in a sense. And this made a world of difference for him and for me. And I know his quality of life was far superior to that of my mom's 12 years ago because of those services. But there was no one to address the clinical needs. It's only gotten better since. So when I had the opportunity to help rural communities develop care coordination, I really stepped into this role with a passion, because I know the importance of care coordination to an individual person, but also to the caregivers of the people that you are coordinating care for, and that you are filling that clinical void that I experienced with my dad.
I just love this photo, and I think you have his smile.
Thank you. Shortly before I came to the center, which was over 7 years ago now, the staff had just finished a study on care coordination or case management, because it was just starting to happen in the hospitals and clinics that we were serving. The intent of this study was to support rural networks in an awareness and understanding of some of the emerging care coordination models. In the next 3 years, we saw care coordination changing almost as fast as technology. So in 2017, we embarked upon updating those materials, and the finished product was this care coordination canvas guide. This tool is a tool that I often use when working with organizations just like yours. With the information that we gathered in the study, it was very clear that there were 4 common components. There was always a target population. There were always somehow assessments that were used. There was always a care team and a care plan. This is our farm's care coordinator. Her name is Arya. Her target population is our small flock of 12 sheep. She does the sniff assessment every morning upon going outside and does an ongoing visual and auditory assessment through the day. There have recently been several losses within a 2-mile radius of our farm to a pack of wolves. And I'm convinced Arya is the reason that that pack has not struck our farm. The care plan for our sheep is to keep them safe from predators, whether it be humans, wild, or domestic animals, to bring them in at night and during inclement weather. The care team, of course, is Arya, and she's definitely at the head. And I would like to think that my husband and I are part of that care team as well. A simple way to illustrate some of these components of that care coordination canvas tool. And this was developed based upon our experience developing the guide. Originally, we designed it to help organizations develop care coordination efforts, but we soon found how organizations with mature, well-developed programs were using it to evaluate their current efforts. We also use this canvas to set a foundation of what we mean when we utilize certain terms, programs, or processes in that care coordination model. Or simply put, developing a common language. As a result of us going through this today, those of you in attendance now will have a common language when you're talking with each other, just because you understand what those different components mean. In June, you're going to be hearing from peers as their organizations have used this tool and some of the benefits that they've gotten out of it as moving forward, to give you some good concrete examples. There are components of this care coordination canvas. There are 4 quadrants or components. The target population, assessment tools, care plan, and the care team. As I've outlined, there are the 4 components in this canvas, each necessary for a successful care coordination model, but we also found that there are 2 additional elements that are critical for success. And these are integrated into each of the components, each of those 4 components. And they are communication and technology. A few points about how they each contribute to your care coordination effort. With communication, how will you communicate to each other in those different quadrants? How will you communicate to the person you're coordinating care for and keep in that loop? And how will the care team be continuously kept in the loop? And then when we look at technology, it definitely plays a role in identifying your target population. For the assessment, it often performs it, it stores it, and it sends it. EHRs play a major role in care plan development and is used by the care team. So communication and the technologies that allow you to communicate better are really key in developing your care coordination program. When I was working at finding people to share with all of you how they have used this Canvas in June, one of the gals I talked to said, I just love the probing questions, particularly around communication and technology, because they're things that we don't think about and they make all the difference in the world. Finally, there are two other components. These are really important with a care coordination program and are key to being successful in implementation and sustaining your care coordination program. One of them is collaboration. Care coordination may be the linchpin for healthcare transformation, but the linchpin for care coordination is collaboration, which we will touch on in two other upcoming webinars. And then what are the social determinants of health? All those things that affect a person's health beyond your clinical care, which, as I've said before, we will be talking about next month. The target population, it's improving the care, the health, and reducing costs for a very specific group of people. As we begin using the Canvas tool, we need to ask ourselves questions like, is it specific enough? Are you clearly defining the goal or the outcomes you want for that identified problem, for that person group or that people group you're working on? In order to do that, the target population must be specific and it must be measurable. Another question is, how will we identify this target population? And third, how will we communicate with and engage the person? And then how will technology be used? To illustrate these points, I have what I call a case study. And this is an organization that I worked with in rural Kentucky, where they were working at establishing an integrated behavioral health program. So we have to ask ourselves, is it specific enough? Originally, they said everyone in our area with mental health issues is our target population. Well, that's really too large, and it's also not easily identifiable or measurable. So you can see here, after working at it, it was narrowed down to any persons with behavioral health diagnosis or need that presents in the emergency department or in one of our member clinics. The goal or outcome for this population is to reduce emergency department visits and increase access to behavioral health services, and finally, connect with needed services. Assessment tools, which is a tool or survey used by the care coordinator, case manager, triage person to assess a person's level of need, either clinically and also socially. It's used to determine those social determinants of health that we've talked about, as well as the risk or severity level of a diagnosis or disease. In our case study, these were the specific assessments that they used to determine where that person was at clinically. They had some thresholds. Eventually, if they scored a certain number on a few key of these assessments, they would be triaged into inpatient care. If they scored another certain number, they would an appointment would be made for them within 24 hours, and so forth. So the assessment tools are really helpful in figuring out what to do next and where to go and best help them. And then there's the care plan, which is an individualized plan of care that is developed with the person and or caregiver and providers. It's used to identify what that person needs, then create an approach to meeting those needs. And we need to think about, is the care plan developed with the person and family, or by just a clinical team or by an individual? Because if we can include the person and or caregiver that we are providing care for in that planning process, the likelihood of it being carried out is a lot more successful. And then what is included? When you look at the guide, there are many important components to take and list in there. Too many to list right now, but it's your usual demographic kind of data, as well as clinical data and their goals. And we have to think about how the care plan is communicated and how we use it to engage the person and communication between the person and care team. And then how will we use technology to use and aid these? Care plans are developed with an individual based on their needs and with clinical and beyond, and the whole person is considered in these various components in the case study, such things as their demographics, their goals, their outcomes, their clinical needs, their instructions, their interventions, the care team names, and their social needs. In the case study, they determined that the social determinants of health, I should say, in the care plan. In most situations, the social determinants of health are included within the assessment phase. But they look at, and they do this primarily in person, with their in-person encounters. They use the electronic health record because they had a form in there called the Prepare tool. Some of you may have that within your EHR, which is a protocol for responding to assessing patients' assets, risks, and experience. And as I said, it's often in the EHR, in your EHRs. Doing it in person and doing some of these in-person interviews is very important when developing that care plan. And they also use community paramedics in order to determine what some of those social determinants of health are, because they are able to go into the home. So in our case study, the social determinants of health are in a different place. However, most commonly they are in that assessment phase. The final component is the care team. And these are the providers, both clinically based and community-based, identified with the person and or caregiver that represents the clinical and behavioral health and social services, perhaps long-term care needs, and very importantly, those community resources needed to meet the person's goals or outcomes. And the guide for this tool leads you to having that whole team of persons to work with and gives many examples. These are just some examples of who might have been on an individual care team in the case study. Not all of these were on everyone's care team, but in many cases, most of them were, from physicians to behavioral health consultants to case managers, families, pharmacists, their support team, sometimes police, sometimes EMS was part of their care team, as well as faith communities. Remember the two components that undergird all four components, which were collaboration and social determinants of health. So looking at our case study, these were the common organizations that they would collaborate with for their persons. Area FQHCs and rural health clinics, a critical access hospital, public health from 2 different counties, EMS, behavioral health clinics, Board of Education, in some cases hospice, community development, and community health workers. Their top social determinants of health were transportation, economic status, education, their living environments, and health behaviors, which I would guess some of these would be very common social determinants of health in your organizations or within your patients as well. The Care Coordination Canvas tool has provided and has proved to be very valuable for hospitals and clinics to build their care coordination programs on, to expand their programs, and improve and strengthen their programs. This will be a resource for you as we move through this webinar series over the next months. You'll be receiving this with the recording. There is a wealth of information in this kit and in this guide to help you with moving forward and using it within your organization. In the appendices, Appendix A is the Care Coordination Canvas at a glance, much of what I've gone over already. And the part that will be extremely valuable to you is Appendices B, which is a worksheet for you to use within your teams. It gives you workspace for each of the quadrants for you to work through with your team. And this is a process that can be done over time. So you may choose to focus on one of the 4 quadrants at one given meeting, or you could focus on just one piece of each of these quadrants at your regular meetings. Truly a workbook to guide you through this process and use it as it fits within and for your care team. We set out today to draw the connection between care coordination and population health and value-based payments. And care coordination is at the center of these value-based payments. And it's at the absolute center of moving that needle on population health. We set out to define the Care Coordination Canvas components, and you will have this guide to help you and your team walk through this flexible, adaptable structure. And you'll have the worksheet in the guide to identify the components within your organization and discover areas that could use strengthening and those areas that you're strong at. We'll be adding a few more appendices as we go through the coming months for your teams to be using. One of them will definitely focus on social determinants of health, and another one on collaboration building. I encourage you to begin to use the worksheet to sketch out what you're currently doing around care coordination and find the elements that you're strong on and the ones you may need to work on a bit more. The use of this worksheet is a great way for your team to get talking the same language and a way of bringing each other up to speed. It is, if you want more details about doing this, joining me at that office hour is a perfect way to be taking and doing it. However, if you want access to this guide sooner than you're going to receive it with the recording, but also if the recording is your first way of listening to it, they won't include the new appendices, but this is the base guide. Go to our website, ruralcenter.org, and in the search box, search Care Coordination Canvas. And this is what your search will show. And go to the Care Coordination Canvas, which brings you to this page, which is that original guide that was developed. And you can download the guide, can download the worksheet, and download the Canvas itself. It's all just right there for you if you want it sooner by going to our website and I ask that any of you jot down questions between now and May 9th. and bring those questions and we can talk through how to work with your team and how to effectively hold team meetings if you would like, as well as any questions about the various components. And at this point, I'd like to open it up for any questions. We have about 5 minutes left.
And just as a reminder, you can go ahead and unmute and ask away, or if you don't have sound, go ahead and we'll watch the chat box. This was such a nice review of the Canvas. Do we have any questions? So what would you say, Deborah, between now and next week? We have an open office hour set up for an hour where they can tap into you as a resource. What would you recommend that they think about, kind of like what's some takeaway to talk about behind the scenes as a group and then to meet with you again?
Would be to take and talk about those 4 components. What is your primary target population that you are caring for? And not saying everybody. I mean, is there a certain condition that you see come in that door a lot that is costing your organization money, time, energy, that is a major issue within your community? So what specifically is that target population, and start thinking about it and thinking about how you identify it. Do you just do it through registries? Do you mine some of your data to discover that? But just think about that target population. And then once you've got a person identified, I find it probably the easiest to choose a person, somebody that you all know, that you're familiar with, an actual person, and then say, okay, so this person is in our target population, and let's say it's Harry. And so how do you figure out how sick Harry is? Or how do you figure out what kind of clinical care he needs to have? What do you need to follow up on Harry with? And what are those things that are happening in that other 80% of his life? Just start thinking about those things. And then think about, well, how do we take, now that we know this is where Harry's at, how do we decide what we're going to do with Harry? And so that's your care plan. And so just thinking through, a scenario until you get all of the materials for a workbook, really choosing someone from that target population and how do you care for them, and how you're, moving the needle on their health. Are they becoming more compliant? Are they becoming healthier? Are they, what kinds of things are barriers in them becoming healthier? And then we can start talking about actually applying that to that workbook. And by then you should be taking and having that workbook in your hands so you can start using it. And then talk as a team about how can we invest in ourselves and in our patients that we're working with to really go through this and figure out what our strong points are and some things that we might need to strengthen. Because I'll say over and over again, we need to have a narrower population to build a system, to build a workflow on. My head always goes to like a machine of some sort with lots of gears in it. And we get that base machine working well and well oiled, then it's time to start to expand it. So maybe you focus on congestive heart failure because that's a real common thing. And then move to COPD because that's like the second most common thing. And just change the gears a bit or add more gears to your workflow. So
I think well said. And those small plans of change, the PDSA, Plan Do Study Act, is what you're basically describing, is start small. Mm-hmm. Like you said, one patient, and iron it out with one patient, then bring on 2 and 5. You suggested congested heart failure, a good one. I'm curious, can people put in the chat box or just speak and say, what are you guys thinking of? Are you thinking of your CHFers? Are you thinking of your hypertensive or pediatric? What are you thinking? Just curious across the board. Yeah, I can see Pat's comment too. Love this. Great way to break it down and start small and build on the process. Someone's going to start with pediatrics. Good one. Diabetics and hypertension. COPD.
And CHF. One thing I always encourage you to have somewhere around 100, 120 people, if possible, in your target population, because then I think you can get some data to see how you're moving forward. And that's not too cumbersome to really begin a program with. And if you're more comfortable, like you're going to take in here when Nadine talks, for example, they started with 5 and they've expanded from there. So just, start mining some of that data. And when I see CHF and COPD, just making sure it's not too big. But I can see CHF and COPD seem to be some issues for you in your state.
Agreed. Well, we got 2 minutes left. Do you want to talk a little bit more about just how they can tap in? What's the access code and all that to get in? Should we we'll be sending that out by calendar invite, so you'll have that.
Yeah, for the office hours, it's going to be a Zoom meeting just like this, where we'll host a Zoom meeting and you come on in and if you can't join right at 12:30 but can join at 1, that's just fine. And if you only have 10, 15 minutes, let us know right away and we'll try to answer your questions first. And so it is a calendar invite. It's also, and Ashley, maybe you can explain the state calendar that you uploaded things to. We will also be forwarding some of those links for all of the next webinars to, there she is. She put it in your chat box where to go. Mm-hmm.
And we are going to switch that up a little bit. I know that we have it posted on the calendar, but we've had a lot of feedback here recently that they really want those individual calendars. So we'll go back to that and we'll be sending out the calendar invites, and then plus you'll have it, if you're looking for it, also out there on the statewide calendar. Yeah. So, and if you haven't already, put your email address in the chat box so that we have it and that we don't miss you when we send invites out. I'd like to thank you for today, Deborah, and all of you for chiming in. And this was recorded. So if you are looking to have somebody else at your facility listen in, we'll have it posted to our virtual library. So if you need help accessing the virtual library, reach out to us and we'll get you access to that too. So thank you, Deborah.
Okay.
Thanks everybody for joining today. Thank you.
Great. Goodbye.
Bye-bye. I'm just saving the chat. So, okay. I'll tune out. Deborah.